Good afternoon, everybody, and welcome. I'm Kim McGrail, and I'm a professor in the School of Population and Public Health in the Faculty of Medicine and Director of Research with UBC Health. Thanks for joining us today for this first session in our Health After 2020 dialogue series. Before we start, I want to acknowledge that UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people. And the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I'd also like to acknowledge that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you're joining us today from many places near and far. I acknowledge the traditional owners and caretakers of those lands. And today I'm calling in from the territory of the Coast Salish people, the Squamish, Tsleil-Waututh, and Musqueam nations. So I'd like to make a few comments about UBC Health and the Health After 2020 program before introducing our speakers. The UBC Health works under the Office of the Vice President of Health, and we recognize the growing need for collaboration to address complex and interconnected problems facing society. We facilitate conversations across disciplines, faculties, and campuses, as well as with the health partners and communities. Our work enables us to improve the ways we collectively train people, the ways we develop knowledge, and how we shape policy. Our ultimate goal is to address inequities and improve systems that foster and support health. Through our initiatives, we aim to foster an active community of health research practice and mentorship. And the UBC Health Dialogue Series brings together scholars, students, and community partners to discuss important topics related to the health and well-being of society and advance interdisciplinary knowledge translation. Our understanding of the determinants and the experience of health and well-being has changed. In 2020, the COVID pandemic accelerated some existing trends and put a spotlight on others, and we're now responding to the broad effects of the pandemic. We have the opportunity to learn from our collective experience and to think differently about how we define and value health, how we understand complex systems that produce health, and how we rise to the challenge of supporting equity in health across individuals, communities, and societies. So in response to this opportunity to affect that change, UBC Health developed the Health After 2020, a program designed to support researchers to engage in interdisciplinary collaborations and build a community of UBC Health scholars. Through the development of research collaborations, academic outputs, cross-campus conversations, and open dialogue sessions, the program convenes and informs people at this inflection point in our society. 8 interdisciplinary teams have been funded during this inaugural year to advance and disseminate their collaborative research, which includes leading a dialogue session, which is what we're doing today. So this first session in the dialogue series is titled Lost in Translation: Why Studying Sex Gender Differences is Not Enough to Move the Dial on Women's Health. So I'm going to hand it over to our panelists now. I want to point out that their longer bios are available on the UBC Health website. Just for a quick introduction, we have Dr. Lisa Galea, who's professor in the Department of Psychology, Faculty of Arts at UBC. Dr. Gillian Einstein is professor in the Department of Psychology and Faculty of Arts and Science at the University of Toronto. And Dr. Natasha Raja, who's professor in the Department of Psychiatry, Faculty of Medicine and Health Sciences at McGill University. So please welcome Lisa to start us off.
Thank you very much. I had to stop sharing so that I could unmute myself because for some reason I couldn't find the unmute button. So thank you everyone for joining us. We're going to spend the next hour or so talking about what we think that is really important to study, put a spotlight on women's health, that the sort of current focus on sex differences and sex and gender-based analysis is not enough. And I thought I'd start us off by just defining sex and gender before I hand us over to our speakers. And that when we talk about sex differences, we're talking about the biological and physiological characteristics that define males, females, and intersex individuals. Whereas gender, most people think of as a gender identity, but is actually much more than that. It's how a given society, from all different levels, educational, work, life, home life, what that society deems appropriate in terms of your roles and expressions and attributes based on your gender identity. So here is my spouse who identifies as a man, showing you what's appropriate in terms of Canadian household work. And now neither of these terms are binary. And even though we'll be focusing more on the sort of biomedical women's female side of things, that's not to say that people of color, Indigenous, trans, and gender diverse people will have many-fold times the disparities that we see when we talk about women's health disparities. It's really important to acknowledge and understand that these different communities have unique needs and unique differences in terms of health and disease risk. And I put some really great researchers on the bottom of the screen there if you're interested in learning more about that particular health. So without further ado, I'll just say that I'm choosing to use my family to show you pictures of males and females, men and women. I think you can notice a number of differences between them across the lifespan, and you're probably very well aware that women are more likely to live longer than men, but they're also more likely to suffer from chronic diseases more than men are. And this is my mother, who suffered from a very severe form of Parkinson's disease towards the end of her life. And this study came out a couple of years ago showing that women on average were diagnosed 2 years later than men were for the very same disease. And there are many reasons, both on the sex and gender side, for this. One of the things I'll just point out very quickly is that even in diseases where you see a greater prevalence in females or women, they're often said to have atypical symptoms. So just think about that for a second. Atypical symptoms in a population that displays the disease more. Part of that reason is, for many reasons, but is because the medical field has really used males and men as a default system. So today, we're going to hear from Jillian Einstein first, then Natasha Raja, then I'll talk a little bit, and then we'll hear from two fantastic trainees about and they're going to interview the rest of us, and then we'll turn it over to the audience. So without further ado, I'm going to stop sharing so that Dr. Jillian Einstein can unmute and share her screen as well. You might need to, yeah, there you go.
Great. Thank you very much, Lisa. So I entitled my talk Strange Bedfellows. Women's health and sex differences. And somehow they have gotten into bed with each other. And I wanted to give a little bit of a historical introduction so we could maybe look and see how all this happened and then maybe begin to disentangle it. So first of all, how did they become conflated? For women's health, well, first, we start with the lying-in hospitals around women's reproductive lives and giving birth. And the first one was the General Lying-in Hospital in London in 1767. Lying-in hospitals didn't make it to North America until 1922, when the Boston Lying-in Hospital was founded and the Grace Maternity Hospital in Canada. And from this time forward, really from the 18th century forward, male doctors dominated the world of women's health at that time, which was basically child gestation, childbirth, and delivery. And second wave feminism in 1960 was about taking back our reproductive health agency from doctors, having women do their own speculum exams, their own pap smears if they could possibly do it, and to really take hold of their own health. And that was the second wave feminist movement. And that lasted till about 1980. In the middle of that period, maybe the most famous book on women's health, Our Bodies, Ourselves, came out of the Boston Women's Health Collective in 1973. And it really galvanized the women's health movement. But still, women's health was very focused around the reproductive body. In 1990, the United States established the National Institutes of Health Office for Research on Women's Health. And in 1994, Marianne Legato established that cardiovascular disease is also a women's health issue. So we went from something that you might call bikini medicine, that is the breasts and the genitals, and that being women's health, to all of a sudden moving toward cardiovascular disease and other body systems. And in 1995, actually, Canada had the foresight to established centers for excellence in women's health that were not just about bikini medicine, but were also about women's life circumstances. They were very concentrated in communities, and a lot about, as Lisa described, gender. And in 2000, we became the first country to establish the Institute of Gender and Health at CIHR, which really in its early days under its first director tackled problems of women's health and gender. But at the same time, sex differences research was burgeoning. So in the 19th century to the early 1900s, there began to be a fledgling field of studying hormones. Brown-Séquard was grinding up monkey testes, claiming that testosterone was the elixir of life. Ernst Lecoeur was grinding up mare ovaries, trying to isolate estradiol, and therein developed a lot of the field of hormones and how hormones could stave off disease or pregnancy. Between 1950 and 1981, there was really the development of this academic field called Hormones and Behavior by Frank Beach. And in 1990, there was the founding of the Society for Women's Health Research, which really began to take this idea of sex differences research, which was really about sexual behavior and how it played out in the brain, to studying sex differences in humans as well. In 2001, there began to be a sex differences research comparing female and male, LGBTQ, and at the same time, the Institute of Medicine report came out really under the goading of Florence Hazeltine and the Society for Women's Health Research to show that sex mattered in the biological contributions to health. And this became a really galvanizing book that began to galvanize sex differences research. In Canada, there started to be something called GBA. Health Canada and the Status of Women Canada took up Margaret Eichler's bias-free analysis. In 2005, there was the founding of the Organization for the Study of Sex Differences, which Lisa is now the president of. In 2010, CIHR added the question about sex and gender differences to our research grant applications to make sure people were taking sex and gender into account. And in 2011, GBA Plus was born at Health Canada. And finally, I put as the crowning achievement on the development of sex differences research, the CIHR chairs in sex and gender science. So this is really my view of how these sort of key moments, but you can see there's a lot of intertwining. And actually, as this has happened and women's health has become about women's all over body health, it's really developed into sex differences research. And so I'm leaving you with a question of how did women's health really become conflated with SGBA+, because we've lost the focus of women's health as we've developed sex differences research. And I think one of the reasons is that there became a focus on sex differences research because they felt the evidence in sex differences research would lead to better health for women, that in some sense it was strategic to call it sex differences research instead of women's health, because as some of you may know, women's health was never highly respected. In fact, there's the politics that women's health was looked down upon and sex differences research would not be, because it seemed more legitimate because it included males. And then of course, sex differences sells. And I just put up only a few of the many books on sex and gender research, popular books that have galvanized the public to be interested in sex differences. So in some sense, it sells much better than women's health. So just a few questions to leave you with. Why keep women's health after 2020? And I think my colleagues, Lisa and Natasha, will convince you of why. I just want to say broadly that it will allow a deeper understanding of women's bodies. For example, we talk about menopause, but in fact, the menopause is not monolithic. There are many menopauses. Some of them occur when women are 35 years of age, and some of them occur when women are 45, and they're not the same as the one that occurs when women are in their 50s. Can we reclaim women's health as it involves all over body health? And that's really the question, I think, before us today. And I think we'll have a lively discussion, and I'm looking forward to it. So thank you very much.
Well, thank you, Jillian. While you stop sharing and Natasha starts sharing her screen, I thought we just release the first question that we have to our audience, which is, and those of you that are not at CIHR might not understand this, but this is how much do you think sex and gender-based analysis research has increased after the mandates at CIHR? So Jillian, Dr. Einstein just introduced this, saying that was in 2010 that we had these mandatory boxes. So we have some data for you to show a little later on, but curious to see what you guys think. And you can think about this as SABV for those of you that are in the US, or Horizon Europe's, I don't know what you call it, gender something. So without further ado, Natasha, can you unmute yourself so that you're... And Natasha is a professor, I think, in psychiatry at McGill University, and she's going to tell us a little bit about menopause and how that affects the aging brain. Yes, there you go.
There we go. All right, always the person that forgets to unmute. So let me just, my slides going. So thank you, Lisa, for inviting me to participate in this important conversation. Lost in translation, why studying sex and gender differences is not enough to move women's health. My role today is kind of to tell you a bit about the story, my story, and how I came to looking at women's health and sex and gender-based research in the recent past. I'm traditionally not a sex and gender-based researcher. I now consider myself one, but I'm a newbie. So I just want to tell you a bit about what I do. So I'm a cognitive neuroscientist by training. So I study how the brain encodes, stores, and remembers new memories about personally experienced events, which I refer to as episodic memory. That's the term we use. So episodic memory is critical for establishing our sense of self. If we don't remember our past, how do we know who we are, and how do we plan for the future? It's a very critical ability that declines with age. And so historically, I've been studying episodic memory function in healthy young adults and in healthy older adults. So I've been asking questions like, how does the brain encode, store, and retrieve past experiences, such as the who and what of what you just saw, the how you experienced the past, and then the where and the when of your past experiences. So these kinds of memories are very important in aging because that tends to decline. So for example, remembering where you parked your car in your office parking lot, that becomes more challenging as we age. Remembering whether or not you took your medication at the right time or in the right order becomes challenging as we age as well. So there's a really important reason to study the cognitive neuroscience of episodic memory in healthy aging. So I've been doing that for the past 20 years, and here's some of the studies I've done. So we have shown that with advanced age, your ability to remember the where and the when, the spatial and temporal context memory, declines with age to a greater degree than just recognizing what you saw in the past. And we've used fMRI, which is functional magnetic resonance imaging, to see how does the brain activate different systems as it encodes and then remembers these types of episodic memories. And so we were doing this to basically understand, why are there age-related declines in episodic memory? And one thing a reason this is important, in addition to the fact that we see these declines in aging, is that episodic memory decline is one of the earliest signs of Alzheimer's disease. And so we really want to understand what was happening in normative aging as a comparator for the Alzheimer's disease groups that we also study. And so in doing these kinds of behavioral studies, myself and many others have identified a large distributed multiple networks in the brain that are engaged in episodic memory tasks. I'm not going into detail here, but the traditional parahippocampal cortex, hippocampus, midline cortical regions, and the parietal cortex have been shown to be important for episodic memory in healthy young adults, and age-related declines in episodic memory have been related to declines in activation and altered activation in these brain systems as well. And we've, in my lab, have focused a lot on prefrontal cortex function and how that changes with age and contributes to episodic memory decline. So that's kind of like the run-up to what got me into sex and gender-based research. So a lot of people were doing young and old, but very few people were looking at the adult lifespan and trying to understand how does this memory decline and brain systems decline from young adulthood through midlife to older age. And here I was like completely ignorant, just, oh, I'm just going to look at age across the lifespan, not thinking about sex and gender effects. And so we conducted a lifespan study, a Montreal adult lifespan study between 2013 and 2018, where we collected behavioral and imaging data from 170 adults between the age of 19 and 76. 70% of these adults identified as female on a self-report of sex. We didn't have a gender identity question yet. This was pre-SGBA when it started. And what we found was, oh, there is, here's the females and males. There is an age-related decline in episodic memory, as we'd expect. But what's going on here, right? So what we noticed was at midlife, especially in females, there was a group of women that were just performing below the mean and below the 95% confidence intervals. And so we wanted to know, like, what's going on? Why are our middle-aged adults performing so much worse than we actually anticipated them to perform on this task? And it was kind of, I'm embarrassed to say with Lisa and Jill in the audience and all of you, but it was kind of like, oh yeah, menopause. It was one of those moments where we were just looking at age and looking at behavioral decline across the lifespan, not really considering women's health. And the reason we didn't consider it is because when we've traditionally always looked at age and sex and gender-based analysis, we've done the SGBA, and there are no sex effects. And there were no sex by age effects in our behavior. So we never really thought too much about sex effects in our data because it wasn't about sex, it was about women's health. So when we pulled out the data from the middle-aged women and we looked at the effect of menopause, what we noticed was that, yes, indeed, the middle-aged women that are performing significantly worse than what we expected on these episodic memory tasks were middle-age and early menopause. And compared to our premenopausal and perimenopausal women, they were performing significantly worse. Of course, women's reproductive aging is intertwined with chronological aging. And so this effect is wiped out if you just look at age. So if you covary out age, the effect of menopause goes away. But when you look at age on its own in relation to behavior, the effect is actually weaker than if you look at menopause versus pre and perimenopause. So this basically was a light bulb moment in my lab, and we concluded that we really need to consider women's health, not just SGBA, when we look at age-related memory decline. And that launched our current study. So I'm going to put a little plug for this study that I'm collaborating with Jill and many others to look at brain health at midlife and menopause, the BAM study. And this study really built off of our lifespan study and what we learned about midlife and the effect of menopause. We're focusing on how does menopause affect the neural correlates of episodic memory? Does this interact with ApoE genotype, which is a genetic risk for Alzheimer's disease? And the study was launched in 2018. Of course, COVID. So it's still going, and we just put in our CIHR, fingers crossed it gets funded so we could complete the study. But we essentially recruit middle-aged adults, males and females, through an online portal. And then they come in for 2 visits in my lab at the Douglas Research Center. The first visit, we get blood, they do a bunch of neuropsych and questionnaires, and then they come in for an imaging session. So we have collected, this is the imaging task we do, a very complex episodic memory task. I could answer any questions later, I'm not going to go into it. But we have been able to collect 90 women to date on this study, and we have their imaging data as well. And I just want to show you the preliminary behavioral results where we look at 46 pre-peri versus 44 post. The peri do fall in between, but for sample size reasons, we group them with the pre. And you can see that consistent with our lifespan study, there are significant effects of episodic memory decline at menopause. in women. And when we look at the imaging data, so this is preliminary imaging data, this is an activation profile, this is the age correlation, this is the memory correlation. When you look at the postmenopausal women, you can see that they're driving this effect. And we're seeing age-related declines in all of these brain regions at postmenopause. This is middle-aged postmenopause, so they're young. And that is related to the decline in memory function. And these are the same systems that the pre and peri women are using to do the more challenging version of the task. So we're still trying to, decipher what this all means. But the take-home message is that really it's important when you look at midlife and in women to look at menopause and not do what we did in the past of just grouping the men and women together and considering only sex and gender and not women's health. So I'm really happy to be doing this research. I think it's very important. And I thank Lisa and Jill for being mentors to me as I've come into this field, and I've learned so much from them. And yeah, I hope to publish some cool data and answer some of your questions about the challenges faced in doing midlife research as well. It's very hard to do, but we're trying. So thanks, Lisa. And that's all I have to say.
Thanks, Natasha. That was fantastic. So while you you stop sharing, maybe I can do this, and I will share and just briefly tell you about another aspect of my research, which is slightly different than what Natasha and Jill were talking about. And then I'll talk a little bit about why, give you some data on SGBA versus women's health. So I just want to share some of the research we do on female-specific experiences and how they affect brain health. And the one that we typically look at in my lab is, or one of them is pregnancy and motherhood. And I think, with the advent of Demi Moore posing naked on the cover of Vanity Fair in 1991, now you can't go by, scrolling or in a checkout stand in the old days, without seeing the latest celebrity or royalty that's beautifully pregnant. And so I think there's this idea out there that it's this glamorous, wonderful experience. And I just wanted to, and it is great. You do get a beautiful prize at the end of it, but I just wanted to share with you the worst picture of me ever taken in my life to prove a point, which is it actually is quite a tremendous toll on a person's body to be pregnant and to give birth. And yes, it's a bit unfair because I'm postpartum here, but there's a whole field of research called maternal adaptation, which is about how cardiac system needs to change. So it increases by 50%, the lung capacity decreases by 50%, a whole host of immune interactions that have to change that we still don't know that much about. Metabolism changes, as well as all of these hormones are increased at such high levels. So we're talking about 200 times normal levels for estradiol at week 20 and 300 at week 30. And we're not talking about, a day or two in acute exposure to these really high hormones. You're talking about 9 months of exposure. And then what happens with the expulsion of the placenta, the birth of the baby, is that people are hypogonadal for about 6 months after they've given birth. So maybe it shouldn't be so surprising, given all these adaptations that occur, that it might not have some repercussions for disease and disease risk. And there are certainly some short-term implications and long-term implications. There's some well-known cancer effects that are positive. So you're less likely to get ovarian cancer, certain types of breast cancer after giving birth. But actually, after giving birth, it's the greatest time of risk to develop depression in a person's lifetime, as well as anxiety disorders like obsessive compulsive disorder. So we've been studying short-term and long-term effects on the brain to see how this might contribute. So I don't have time to talk about many of these effects, but I just wanted to show you a couple. This is some data from human brains showing, this is from Oatridge et al., showing that this is time series parturition. So there's about a total volume decrease of about 6 to 8% that bounces back 6 months later. But other people like Hoxima have looked at my favorite brain area called the hippocampus, because it's really important for memory and emotion. And this blue here is during pregnancy, and you can see that it decreases. It's 2 months post-pregnancy, and there's a bit of a recovery, but not a complete recovery. So while some brain regions have a complete recovery, there's not a full complete recovery everywhere. And we see the same kinds of things in animal models. The way we look, one of the attractive things about the hippocampus is it's really plastic. So it has the ability to produce these new brain cells. And when we look at first-time moms, that's the ones in pink here, you see during gestation, early postpartum, and even late, this is after the pups have left the nest. We can talk about what that might mean in humans if you want later, but we see a reduction in the number of these new brain cells. But that's short-term. What happens long-term? In fact, we actually see the opposite. So Anne-Marie Deling's done some fantastic work looking at the UK Biobank, and what she finds is that people with previous pregnancies, their brains look a lot younger. Doesn't matter how many pregnancies they had, they just look a lot younger. And one of the brain regions that what does look a lot younger is the hippocampus. I really like that because what we found is that in middle age, so not just after giving birth, but much later on, in the dark blue here, these are what we call multiparous animals. So it's many births. We see many more of these immature brain cells, these new brain cells, than you do in rodents that have never given birth. So what I hope we've given you is just a tiny tidbit that female unique experiences can influence health and disease. And there's just so many examples that are out there: hormonal contraceptives, menstrual cycles, pregnancy, menopause, and there are many menopauses. I think there's a question in the chat about that as well. And they all influence the brain and health and disease risks differently. So what happens when we don't study women's health questions? Well, I think a very good example of this is the current pandemic. First of all, men were seen to be dying more from COVID-19 than women were. And I thought at the time, and Bonnie and I wrote a nice blog about this, I'd say, suggesting that if we knew more about women's health from their immune system perspective, maybe we could have more therapies that could help everyone during sort of be resilient to COVID-19. But the other is that when they did the first vaccine trials, they didn't want pregnant women and they didn't ask about women's health questions. And so they purposely excluded people that wanted to get pregnant. But of course, people, do get pregnant. Even if you tell them not to, they still get pregnant. So this is from the early data. This is control group, this vaccinated group. Here are the people that got pregnant just by chance. And you can see there's no big difference. It doesn't matter if it's an mRNA vaccine or the AstraZeneca. And then miscarriages, very low N anyway, but you can see that if anything, they're lower in the vaccinated group, not higher. But yet, this idea that it caused infertility persisted. And now that we know, there are many other studies showing that there's no association and in fact, very bad outcomes or higher risk for bad outcomes if you get COVID-19 when you're pregnant. The other thing that happened, again, remember, there's billions of people being injected with these vaccines. So, there was social media buzz that there were some menstrual cycle disturbances. And it was interesting. I got interviewed from, I think I'm in all of those, as well as many other experts in the area. And when the reporters talked to me, they said, a lot of experts are saying there's just no basis for the vaccine causing any cycle effects. And I said, well, I think that's interesting because nobody's looked. And, this is maybe part of the reason, if we dismiss women's concerns without actually testing them, this is a problem. And when people have tested it, you do see some minor disruptions. And it would have been great if, in the original trials, they asked women about some of these effects or females about some of these effects, because you can allay concerns. Yeah, you might see some spotting, which is what the study on the right suggests, is that you see heavier flows and more spotting. It's about 40 to 60% of people will see that. There's a change in 1 day in a menstrual cycle if you get vaccinated twice in one cycle. So it's not a huge effect. And then the cycles resume their normal cycling. So, the idea, as Dr. Einstein showed us earlier, these new policies that NIH and CIHR have, NIH has SABV, sex is a biological variable, and CIHR is sex gender-based analysis, but are they enough? And I would argue, I'm quite concerned because since 1993, NIH has had a mandate that you need to include females in your groups, but there's no mandate on what percentage need to be in your studies and that you need to analyze by sex. And so what has happened is there was a very recent study that showed that 72% of clinical studies, NIH clinical studies, did not analyze with sex as a factor. So if you're not analyzing, we have no way of knowing if there's a sex difference or not. So that's one thing. And part of the impetus for this was because we didn't know enough about women's health. The other thing is drug trials. So of the new drug trials that come out, 90% of women are showing more side effects compared to men. That was a large meta-analysis that was done. So we asked you this question, what percentage of, so, it was mandated, right? But remember, it was in boxes, mandatory boxes, not in the actual grant itself. And so we actually did an analysis of just the abstracts that people wrote. Did they mention sex and gender in their grants? And can we see the results, Veronica, of the poll? So in fact, the answer is 0%. There's a 0% change in the number of grants that are actually analyzing or talking about sex and gender in their abstracts. It's not 10%, it's not 30%. I'd love it to be that. It is if you analyze the mandatory boxes, people say they're going to do it, but in terms of actually doing it, they're not. Okay. So and that's just, we've only looked in BC and Alberta so far, but our plan is to look throughout all of Canada. But grants on SGBA didn't change. It was 2%. They're very low in Alberta. They went from 1.6% to 1.97%, still very, very low. So we also looked at 3,000 studies in 6 journals across neuroscience and psychiatry. Happy to talk more about it. More studies are disclosing that they're using males and females. Fewer are admitting sex from them, but there are very few of these studies that are actually using what we call an optimal design or an optimal analysis. And if you don't analyze, like a lot of those clinical studies are doing, you'll never know if there's a difference or not. And the other issue is, as we've just shown you, female-specific experiences are important, do have a role to play in health and disease risk. And there are 9 times more male-only studies than there are female-only studies. And that percentage isn't changing at all. Just to tell you very, very quickly that I did a report for the BC Women's Health Foundation where I was asked to look at how many grants looked at women's health research, and it was 8% of CIHR grants in the last 10 years. They were awarded for slightly shorter terms and $200,000 less per term. That's nothing to sneeze at. So this idea that maybe women's health isn't funded to the degree it should be, I think is a real fact. So hopefully we've convinced you in a very short period of time, because we wanted to have some discussion, that we do need researchers to focus on specific women's health questions, that SGBA is not going to be enough. We also need it on non-binary health and gender diverse health, because we do have to understand how these sex and gendered experiences in all of these gender diverse populations are influencing our health outcomes. And I just put this over here just to say that we know that intersectionality matters, and we know it's not just completely additive. It's an important thing to disentangle. So I would suggest to you all that we can't just rely on sex and gender-based analysis to allow us to understand.
I'd love to step in here and just address Geraldine Pryor's comments about menopause.
Should we wait till we do the trainee part, or no?
Oh, okay.
Sorry.
No,
Let's go to them, and then we can go to that for sure. So now I just wanted to introduce our fantastic trainees who are masked up because they're together, and we have a mask mandate at UBC. And it's Bonnie Lee. I gave her an honorary doctorate the other day. So she's not quite there yet, but she's a PhD candidate in neuroscience at University of British Columbia. And Romina Garcia de Leon, who just started her probably she's skipping to a PhD, but just started her master's in September. So I just wanted to ask them a couple of questions, which is not on my screen right now, but I think it has something to do with what attracted you to this, this kind of a field. You can just introduce yourself and give us a couple of minutes of reflection.
So hi, my name is Bonnie. Can you hear me? Okay. And yeah, as Lisa said, I'm a PhD candidate, and my research primarily looks at pregnancy, so how previous reproductive experience interacts with Alzheimer's disease risk to influence the brain throughout aging and in middle age. And so how I kind of stumbled onto this area of women's health research is I was originally interested in Alzheimer's disease research, and I actually didn't realize that women are not only have a greater lifetime risk for the disease, but also carry a greater burden of the disease. So they experience more severe symptoms, more rapid decline in various cognitive domains. And so that led me to think about why this is and why we see this greater burden in females. And one possible answer could be that they have these female unique experiences like pregnancy that can influence their brain, like Lisa mentioned, not only in the short term, but also in the long term and alter disease risk.
Hi, my name is Romina, and yes, I am a master's student at the moment, and I study postpartum depression. What led me to this research was the fact that in my undergrad, I studied sex differences in depression, and there was this large gap in what was happening exactly in the females. And so the question led me to wonder whether these female-specific mechanisms are also playing into the increased risk in depression, for example. And so that led me to postpartum depression. And this is hopefully going to help bridge that gap that is lacking in female-specific diseases like postpartum depression.
Thank you. So now, Jillian, sorry to cut you off there, but yeah, Jillian has a number of questions, and I think it's really important to address them, which we will, and then we'll get to some other questions. I think that I'm going to turn it over to Bonnie and Romina because they're going to host the rest of it and ask us questions. But we do have questions from Jerry Lynn already. So Jillian, if you'd like to, and Jerry Lynn, I'll answer your other question in the chat.
Yeah, so I know that Natasha responded to Geraldine specifically about the criteria she used to define menopause, but I think Geraldine brings up the larger question about how many menopauses there are, which I think I alluded to and Lisa mentioned. And I think it's one thing we don't learn about if we're not actually studying the health of women. If you're just looking at sex differences, you tend to conflate all menopauses as an estrogen deficient state. But when you start, as we have done in the lab, when you start to look at women who are 40 years old and they have their ovaries removed, that's a very different picture with respect to the brain and memory than women who are 50 years old and are going into menopause naturally. So I think Jerry Lynn's point is a really good one, and I want to address it. And I think what's come out of, in some ways, the answer to some of my questions have come out of Natasha and Lisa's presentations, which is that what we lose is we find out that there are sex differences, but we don't delve into what makes the difference for women, and therefore what is going to really enhance women's health specifically. So yeah, I wanted to just speak to that.
Thanks, Jillian. I'll hand it to Romina and Bonnie and then also please do feel free to ask specific questions or just general questions in the chat, and our student hosts will ask us those questions, and then we can just chat together.
Yeah, so we'll just start with a really general one. We know in the beginning you mentioned the differences between sex and gender. And so we do know that they are very intertwined concepts. Can we really divide these two apart?
I want Jillian to take this question again. And actually, Jillian and I are I think, going to have a debate about this with Louise Pilote at a conference in May that'll be in Montreal. And we sometimes think differently, Jillian and I, but Jillian, I think you've thought about this really deeply. So take it away.
Oh, thank you, because this is something I feel quite passionate about. So thank you for asking the question. So this is the reason I started the Canadian Organization for Gender and Sex Research, which, little plug, we're having a meeting in Montreal, May 29th. Lisa and Natasha are heavily involved. Lisa is the co-vice president and Natasha is involved on the program committee, and it's going to be really terrific. And the whole point is that we've gone to a lot of trouble over the years to separate sex and gender. I really think for purposes of doing an experiment. An experiment has to be doable. And if you have too many levels of knowledge, too many different ways that you're approaching the same question, it can get very difficult to pull those together. But in fact, to study sex and gender, you really have to do that. So our meeting is on methods and methodologies, and that's something that we've been thinking a lot about in the lab, about how to bring them together in a single study to really understand how gender affects women's health as well as sex differences.
So can I add to that? So one of the things that's being asked in my lab is about, so we have a very inclusive recruitment. And so we do look at, include individuals that identify as trans in our study. There aren't many, but we don't say no to their participation. And so we do consider sex and gender. And one of the things we've been thinking about, and I think this is probably the debate Lisa, Jill and Louise had, is about the gendered life experiences of women. And so we are collecting more about the social determinants of health in our study, again, just to report in a demographics table, because like Julie had said, you can't do everything, right? So you have to kind of focus on your primary variable of interest and then kind of just say, this is what we know about these women. Make of our findings as you will, based on this additional demographic information we're providing you.
Let me just jump into, although I saw that Jillian also, this is the problem. We could talk like that. I know that we could talk for hours about this. I was just going to say, I did a study with WHRI, which is a Women's Health Research Institute, where we did a survey in BC, and it was over 6,000 people. And we asked the appropriate sex and gender questions. And we did get some gender diverse individuals, of course we did, but they were, I think, maybe 60 people overall, something like that, out of the 6,700. And so it is a really small N at the end of the day. And that's why I think it is important, and a lot of agencies are starting to be aware of this, of having open databases with good variables. This is a problem. In the ADNI database, which is one that for Alzheimer's disease, they actually, I think they ask, what's your gender, male or female, which is the exact, it's not the right, no, it's like, this is wrong on so many levels, I can't even go there. Aeroplan, by the way, Air Canada asks you the same question, but because gender is not male or female, that's sex, and then they're missing intersex. But anyway, you need to have those larger data sets so that you can, answer those really important questions about gender diverse individuals.
Yeah, and I was going to jump in and say that one of the things that we've done in my lab, and by the way, I'm looking for a postdoc. If anybody is interested in a postdoc, please be in touch with me. Google my lab, einsteinlab.ca. One of the things that we've done in the lab is for every experiment that we do that looks at hormone levels or does any kind of brain scanning or any kind of blood analysis for biomarkers, we also do qualitative interviewing of the women to find out what is this like for them. And we learned some really interesting things about what influences the course of their symptoms and their sense of themselves, what these different surgeries and different conditions lead to given their lives. We did a really interesting study actually of Indian immigrant women with chronic pain and asked them to take pictures of their pain. And what it revealed was a gendered life. I mean, they took pictures of the stairs they had to go up and down to do the laundry. They took pictures of washing machines. They took pictures of sinks full of dishes. I mean, it was fascinating. And so I don't think we can not look at gender with these effects that we think are only sex effects, which is why I think women's health is so important, that we can get a whole body view of what is the case when women have ill health or have good health for that matter.
Thank you. I have more to say, but I want to give it back to Romina and Bonnie.
Yeah, thank you for those great answers. So we have another question, and that's to do with something that Lisa, you mentioned earlier on funding. So based on funding, Lisa, Natasha, and Jillian, have you had difficulties getting funded for women's health specific research?
Can I first go? I should really first go. I should give it to Natasha. Do you want to go for that?
You go ahead.
Oh my gosh. So I put in the CIHR for studying the long-term effects of pregnancy, and like Natasha, we're looking at a number of we're looking at ApoE4, which is the greatest genetic risk factor for late onset sporadic Alzheimer's disease, and we're looking at an animal model of this. And the reviewers said something about like, oh, you need to compare this to males. And it really struck a chord with me in a bad way. So I wrote, if you're on Twitter, or even if you're not on Twitter, you can look at my pinned tweet, because I did, I don't know, 20 tweet tutorial about why I didn't need to compare it to males. It just really struck a chord with me, and that's probably when a lot of the ideas for this started to percolate. And not necessarily, this is not necessarily a great thing, but what was it? That wasn't BuzzFeed. It was like some Vice, which is like a news outlet, asked me to write a piece about it, which I don't like. I didn't choose the title; they chose the title for clickbait, but it calmed my nerves a little bit. But yes, and in fact, when I did the tweet, somebody else wrote right away saying they had written a CIHR grant as well on the placenta and had been asked to include males in their studies. And which is just like, how do you, it's hard to respond to that, because males don't, unless you're Arnold Schwarzenegger in that old movie where he gets pregnant, it doesn't happen. So thank you for that question. But I do worry that I think the findings we found in Alberta were that the women's health grants were going down actually across years. And so I do worry about that, because we do need that focus on women's health as well.
I mean, I completely agree with you. And I think that's why sex differences research was really born, because I think that everybody who worked on women's health had a really difficult time getting funded and getting people to understand that women's biologies are very different from men's, and that it's an important biology to study. And so they turned to sex differences as a much more sellable idea. But I think in that, we're learning bits and pieces about females where they're different, but we're not really learning about the whole body and the organism, which I think we really do to improve the lives of women.
Mm-hmm. And my big concern is that even when people are, because there's a greater awareness that there are sex and gender differences, but they're not actually doing that analysis. And if you're, could we launch those other questions, Veronica, now, before I give the cat away with a bag? And I know I mix my metaphors up there, it's fine. So if you can, please just answer some of these questions. There's a few of them, so it'll go through while Romina and Bonnie ask us more, and then we can take a quick look at the answers. So Bonnie and Romina, do you have any other questions for us?
Yeah, so with the given difficulties with getting funding and getting this awareness and spotlight on women's health, do you have any ideas on how we can break the bias and engage more people in women's health research?
I have tons of ideas, but let me go to Natasha or Jillian first.
One of the things I think that's really engaged people in women's health is doing the sex differences first, I find, and saying, hey, there is a difference. Okay, the men are included in this study. We see a sex difference. Now we're going to zone in on the women's health. And when it's framed like that, I find people are more open to it, because it's framed from both sexes, and then men are drawn into the reading of it as well. And okay, that's why you're looking at women. So that's one way that I've approached it, by doing sex differences and then women's health in the projects that I propose. And the other thing that I found I just want to say this as an aside, a lot of times, especially in the cognitive sciences and cognitive neurosciences, people don't look at sex and gender based effects in the brain because they don't see it in behavior. And I just want to say that just because it's not in behavior doesn't mean the way that we get to the answer is the same. And so we've seen that in the lifespan study, where, the reason men and women show age-related declines in episodic memory are not due to the same mechanism. So it's different brain systems that were implicated in women and men. So I think that's another way to increase awareness and funding, is to say, it's not just about behaviors that are different. It's also about behaviors that are similar and how you execute those behaviors.
Yeah, you're
Yeah.
No, sorry, I didn't mean to cut you off. That, like, I mean, you're preaching, like you're singing my song. Keep going. I would like to come at it a little differently. I appreciate what NIH and CIHR are trying to do, but again, I worry because those mandates have been so slow and sort of the uptake. IGH, which is the Institute for Gender and Health, released some Catalyst grants a few years ago, and then all the Catalyst Award winners had to come to OSSD, that's the Organization for the Study of Sex Differences, and talk about their findings. And one of the researchers said, look, I wasn't a sex difference researcher, but we had noticed a few sex differences in our data. So we started we wrote this grant, and they didn't get, this is a very famous researcher, and he didn't get the first grant he wrote. And it humbled him. And I think that's really important, right? Like, so I do think that when I always say, when you build it, he will come, which is a wrong quote. But if you put shiny money in front of researchers, we're going to go for it. So if you say, hey, here's a whole pot of money to really do a deep dive into sex and gender-based analysis, I think people will do a better job than sort of mandating it for everyone, unfortunately. But also we need that for women's health, and we need that for gender diverse health. But we do need like those big pots of, that's my personal opinion, to really get people to be thinking about this more deeply.
I was going to say also that, I think women's biologies are different than men's. I think actually they're more complex. And I think it teaches us about the complexity of biological systems, which we're beginning to actually grasp and understand that that's the case anyway. You can't just have one variable and everything controlled. That doesn't make sense for biological systems. And so what I tell people is, if we'd started studying women first, and we were now mandated to study males or men, we would say, no, we really can't do that because they're too simple. They don't really represent the complexity of that biological diversity. So I actually don't think males are so simple, but they're more I can't think of the word, but they fit in better with the scientific paradigm right now. But I think that we have tremendous amount to learn about the diversity of biologies by actually studying women in depth.
So it's so interesting that you say that, Jillian, because I think because we studied males so much, not just us, but like scientists in general, the narrative is all about, so one of the things I study is how stress affects the brain. And so stress will reduce neurogenesis, and those new brain cells will reduce atrophy in the hippocampus, CA3 hippocampus. It doesn't do the same thing in females. And in fact, it's associated with impaired learning and memory in males, but actually facilitated in females. It's really interesting. Probably has to do with the type of stress, just like you were talking about, Jillian, in terms of like the stairs. Maybe stairs is different than something else for males versus females. So, and also, Natasha, we're seeing this very same thing. That's Jill Becker's got some really great visuals about different types of sex differences and how, most people will think of maybe one or two, but not on those mechanistic differences when you don't see a sex difference, but it doesn't mean that the traits are different. And I know it's 1 minute. So I just thought, can we share all the poll results just so we can look at them all? So I think we have a good smattering here of people, and then I guess that can just scroll through while Kim probably wants to come back on and say, get off the screen.
No, what I really want to say is thank you so much to Lisa and Natasha, Jillian, Romina, and Bonnie for what a great launch to this series, and what a informative and interesting and I think I saw the word inspiring in the chat too. That's a great presentation. Thank you so much. Thanks to everybody. And then I want to just draw your attention that we have more in the series coming up on April 8, April 27, and May 11. So please check our website, sign up for our announcements, and we hope to see you at future sessions. Thanks everybody for coming, and have a good rest of your day.